Welcome to today's question and answer session, which is on fear and anxiety, psychological well-being and prevention of psychological distress in chronic lung disease. And this was a recent symposium session given at the ERS Congress. And I'm delighted to welcome 3 expert speakers from the session today. And they will be each giving a short presentation, followed by a question and answer session. And the questions will be being asked today by Rita Berriuso from the Asociación de Enfermos de Sarcoidosis in Spain. So our first speaker today is Dr. Karen Heslop-Marshall, and she's a nurse consultant from the Newcastle-upon-Tyne NHS Hospitals Foundation Trust in the United Kingdom. And we'll first see Karen's presentation.
The presentation I did at the ERS was about nurse-led cognitive behavioural therapy in COPD. We know that breathlessness is a key symptom of COPD, and that symptoms of anxiety and depression are very common in patients who develop COPD and many other respiratory conditions. But generally, we don't screen for these symptoms, and that's a big mistake because the treatment is available, but generally we don't do it because we haven't screened for it. And if you look at what the literature says, it says we actually need to do a large study to see if we can help. So I did a large study in the UK, and we looked to see if an intervention delivered by the respiratory nurses who work closely with patients could reduce symptoms of anxiety and panic, which are very common. But we also looked at, and did this help reduce attendance to accident and emergency or hospital admissions? So we randomised 279 patients who agreed to participate in the study to either self-help leaflets plus a brief intervention with the respiratory nurses using cognitive behavioural therapy, or self-help leaflets alone. And we followed patients up at 3, 6 and 12 months to see if it made a difference. And what we found that the CBT delivered by respiratory nurses reduced symptoms of anxiety. So you can see on the left, the average symptoms of anxiety from baseline to 3, 6 and 12 months decreased in both groups, but the CBT group did better than the leaflet group. And it was also, if you look at the right, it was also a very clinical and cost-effective intervention. So this could be done. But at this stage, you might be wondering, well, what on earth is cognitive behavioural therapy? Well, cognitive behavioural therapy is a psychological intervention where you talk to the respiratory nurse about the difficulties and problems that you may have and how you are thinking about this and managing it. And then together you work out some really useful techniques and strategies that might help. So really, what this study showed is that instead of burying our heads in the sand, we can actually help patients manage their illness so much better by using CBT skills. And I think respiratory nurses have been shown to be able to use these skills to help patients to manage their illness in a better way and have a better quality of life, reduce their symptoms of anxiety and reduce the need to go to hospital.
Hi, Karen. Thank you very much for your presentation. So moving on now to Rita, who's going to be asking the first question.
Yes, thank you very much, Claire. Thank you very much, Karen, for taking your time and dedicating it to us. My question is, fear and anxiety also weaken the physical health of the patient. So a vicious circle is created between bad physical health and poor mental health in chronic conditions. CBT is about breaking vicious circles by changing little actions. During your professional experience, have you been witness of significant physical health improvement due to a better mental well-being, or the opposite?
No, I have been, in my experience, patients' physical health has improved. Obviously, CBT won't magically cure lung problems. It can't do that. But what CBT does is help people look at what they think about their illness and how they manage their illness. And sometimes the CBT can help improve how people manage their illness, which does have a knock-on effect on how they feel physically, but also psychologically. And some of the things we look at is if you're frightened to exercise, then you can avoid doing it. So CBT looks at that and why you do that and what benefits it might have to change the way you behave. And that has a knock-on effect on the muscle strength that you have. If you're more active, it makes you feel better psychologically, your mood is better. So overall, whilst it won't actually physically change any lung function, it does seem to have an overall benefit on physical health and well-being. And of course, we know that physical inactivity is a major cause of mortality and death. So what we do, or I do when I work with patients, is look at ways to increase their physical activity, manage their breathlessness better, so that they are able to do what they want to do. And so overall, I think it does help improve their physical health as well as the mental health. There is no correlation between symptoms of anxiety and depression and lung function. So some people can have very good lung function, but are very anxious and depressed. And that can have a massive impact on their life and their overall health. They're very disabled because of their mental health rather than their physical health. So they can be very breathless, they can avoid doing exercise, and in the long term, that has a negative impact on their life. Alternatively, I've seen patients who have very bad lung function and who are really good from a mental health point of view. And it's all about how you cope and manage your illness. And some people are really resilient and manage very well despite getting breathless. And I think it's very normal and understandable to think that you can get breathless and to get anxious because you're breathless, because it's a horrible thing to have to go through. But it's not helpful. It's like a double problem that you've got. So what CBT helps you do is understand what causes you breathlessness. And anxiety is one cause. The lung problem is another. Bending down is another. Exercising, infections, all of these things can cause breathlessness. But anxiety and panic can make it 10 times worse than it is. So CBT works looking at anxiety and panic. And it doesn't matter whether your lung function's 80%. You can still feel very anxious and very disabled because your mental health is taken over at that point. And I know a lot of people don't think mental health is important, but actually your head's connected to your body and your mental and your physical health are intertwined. You can't escape it. If you're not well physically, it affects how you feel mentally. You can't do the things you want to do, and you might be depressed about that or feel low about that. There shouldn't be a stigma about it because it's natural that you would feel that way if you're not able to do it. But what we need to do is learn from people who really manage well, despite having extremely terrible physical health problems, but they just seem to cope with it. And we need to bottle what they do, and that's what CBT tries to do from my perspective anyway.
It's really a thing that some people do not believe, that your state of mind is really important for your physical shape. It's really important.
No, they don't.
Yeah.
Karen,
and I really appreciate your presentation.
Okay, thank you very much, Karen. So our next expert speaker is Ron Flewitt, who's also in the UK, and he's an expert patient and a member of the Pulmonary Fibrosis Trust. So we're now going to see Ron's presentation that was given at the Congress.
Well, my name is Ron Flewitt. I'm age 59. My condition is idiopathic pulmonary fibrosis. I was devastated, absolutely devastated, because I'd met Maxine and I met the woman that I thought was going to be spending the rest of my life. And at diagnosis, we felt robbed. We felt robbed hearing that news of 3 to 5 years. So, and all I can remember is going home, crying for days, crying at nights, going on the internet, looking at websites, getting frightened of what it said. And yeah, those days were quite dark for us, and our anxiety levels were extremely high. I just felt so alone and so desperate at that point, having no one to turn to for help.
Hello, it's 4:30 in the morning. What a lot of people don't see with lung conditions is I've been up since 3:30, can't sleep, been tossing and turning all night, so I've decided to get up, make a cup of tea and try and break the habit and try and get back to sleep. I don't know whether it's worry, whether it's just the effects of my lung condition, but this happens most days, and I suppose that's part of the fatigue and tiredness of IPF or the medication we take.
Well, from that I was offered Tai Chi, relaxation classes, and I met other patients of other diseases, which sort of helped me as a person realising there's other people out there just as ill as you with different diseases. And my nurse that I see up there realised my extremely low mood, and she said, "Can you go and visit your doctors tomorrow?" So I went up to my doctors at 9 o'clock, and there was an appointment waiting for me. The doctor took me in and he said, "I hear you're feeling depressed, what's the problem?" And I couldn't talk to him as I talked to the hospice nurse. I just said, "Well, I'm feeling down, I feel this and I feel that." And he gave me, and he prescribed me antidepressants, which I was on for 4 or 5 months. So it gave me an uplift. But yeah, it was strange. I could talk to this woman at the hospice, but I couldn't talk to my doctor.
Sometimes when I wake up, I don't feel like exercising because I'm tired, fatigued and low mood. But when I'm finished, it makes me feel good and lifts my mood.
The biggest thing that hurts me is watching my wife do the things that I should do.
My wife has set up my turbo trainer. She's gone to the shed, picked up the bike, set it all up. She set my oxygen up for 4 litres, ready for me to join my spin class at 10:15.
My biggest fear is the breathlessness. I've watched, being a chair of a support group, I watch people that can only walk 5-10 yards or just get out of bed, and it's their breathlessness, and that frightens me. I don't feel I've had the support apart from the hospices where I went to after support. But when I had a large decline back in February 2019, while I'd lost 10% of my lung capacity, the consultant said I've lost 10%, I had to go and see the ILD nurse. And we sat down there and she said to me, I'll never forget it, she said, "Ron, are you okay?" I went, "Yes, I'm fine, there's nothing wrong with me." And she leant across and she put her hand on my arm and said, "Are you really okay?" And that's when I burst into tears, because I wasn't okay. I was doing the man thing, saying I'm okay. And so I let her know how I felt, how it affected me. And then she turned around to Maxine, and it's the first time that someone has turned around to my wife and said, "How are you?" They said, "Are you okay?" And she burst into tears as well.
Reassure the patient it's okay to feel low. There is no shame in seeking help. Put them in touch with other patients, i.e. support groups or buddy systems, and connect them with local charity organisations. Encourage communication. If concerned, patients won't contact healthcare professionals as they feel they are being a pain.
Great. So Rita, you've got a question for Ron?
Yeah, I got a couple questions. First of all, thank you very much, Ron, for being available today to answer. And thank you very much for your presentation. It's so enlightening and so encouraging. And here's one of my questions, because I quite had the same experience, and just tell me if I'm on the right path. Could you say that going to the hospice and watching other people with problems was a turning point for you?
Well, thanks very much, Rita. I first self-referred myself to hospice, first of all, because I realised that I did need some help. I wasn't talking to my wife at that particular point, and I went to the hospice, and it was a turning point for me, because I suppose I wouldn't say wrapped up in my lung disease, but that's all me and the wife were talking about, and that's all. It was about IPF, it was about our daily lives and everything. But going to the hospice actually was a turning point, because I met other people with other diseases, but the same problems as me. I met a lady that had a motor neurone disease, and she was very funny. She made me feel alive, because although she was dying, she still could make me laugh. And I just formed a great friendship with her. And from the hospice, they sent me off. I was struggling sleeping, so I went to sleeping classes. They sent me for Tai Chi, about relaxation. They also helped me to look at me as a person, look at what support I needed. So something like benefits, which I wasn't aware I was entitled to. So yes, going to the hospice was a major turning point for me.
I think sometimes we have to stop looking at us and look a little bit at the rest of the people around us. Don't you think?
Yes, we do. And I think with the hospice, I think a lot of people, it's there for end of life. And I'm now a great, I'll say speaker, or great. I do say to people, if you get diagnosed with a chronic illness, go to hospice, because it's not just there for end of life. It's there to support you as a person.
Great, thank you. Other question is about loneliness and support groups. And loneliness is a common feeling among chronic patients. You mentioned support groups. In my experience, it's extremely useful. But don't you think that isn't it as important as being understood by a group of peers out of your day-to-day circle, being understood by your family and friends? I mean, your support group is supposed to be your IPF members. Your support group, it's made of IPF patients too, but they're not your family, your friends. You live with them in your day-to-day life. What about support groups for caregivers, family, where they learn about what the chronic disease of their relative is about? Because feeling misunderstood by your family and friends and maybe your employers and your colleagues sometimes generates a lot of anxiety, fear, and distress.
That is an absolute great question. I mean, I attend a support group, and I remember the first time I attended a support group and the look of horror on my face, looking at all these extremely ill people on oxygen, not being able to walk from the car park. And I can remember my LD nurse coming to me at the time and saying, Ron, she looked at my face and said, Ron, if you don't want to come back when you're ill enough. And it was quite an horrendous experience for me at that time, because I was quite well. But I turned around to her and I said, well, actually, I think these people need me more, and it's wrong for me to come back when I need them. But the support group has become my new family in a way, because these are the people that me and my wife can talk to. And my wife is part of a carers group that's attached to the support group, where they meet every 2 weeks, where they can say, well, Ron done this, or, is this right that Ron done this, or my husband done this, is that correct? With regard to family, I'm not so sure that would work, because my daughters and a lot of the family actually think, because I look so well, there's actually nothing wrong with me. Because when they phone me, I mean, I suppose I'm not the prime example, because all my daughters live about 200 miles away. So for me to get them to support group would be extremely hard, and I don't think they would appreciate the seriousness of my lung disease, if I'm totally honest.
Don't you find it hard to feel misunderstood by some part of your family? Because I do. Me as a patient, as a lung condition patient, I really found it hard to feel misunderstood, because everybody said, "Oh, you look gorgeous, you look perfect, you don't look like sick, you don't look like you have a disease." And I really struggle a lot to wake up in the morning, to do my course, to do everything. And sometimes I wish they were on my shoes for a while. And it's difficult to tell them, just read a little bit about this condition, and you would love them to be educated somehow on what's going on with you.
It's hard to live in someone's shoes that's got a lung condition. I include my wife for that because I think we both have a lung condition. My family, I suppose, have got their own lives, and my friends, because if I take this off, I look totally normal. People wouldn't think that I'm ill. But that's a difficult question to ask about family to attend support groups. I don't know whether I'd want them to look at a lot of people that are extremely breathless, just walking 10 feet. I don't want my family to watch me going through that pain. Sorry, I've got to put this back on because I was getting a bit of breath. So I don't know, it's a very difficult question to get a support group for families, because I suppose with people with other diseases like cancer, they've got a ring. When you're diagnosed with cancer, I suppose you've got your nurses, I forget what they're called now, the Macmillan nurses that take the family in and say, this is the course of action you're going to experience, you're going to do this, this is going to happen to you, etc., etc. And I think with the lung condition, and this is slightly off of what you asked, when I was diagnosed, it's you've got 3 to 5 years to live, you're on this expensive tablet, off you go. There's a massive difference between someone with a lung condition and someone with a recognised condition like cancer.
Thank you very much, Ron. I loved your presentation. It was so enlightening too, and it was full of hope and full of joy somehow also. Thank you so much.
Thank you.
Right, well, thank you very much to Ron and to Rita. And finally, I would like to introduce Dr. Deborah Reynolds-Sanford, and she's joining us all the way from Australia today. And she's a senior clinical psychologist and researcher at the University of Adelaide. So first, we're going to watch Deborah's presentation.
Greetings from Australia. I'm Deborah Sanford, and I'm a practicing clinical and research psychologist. And I was asked to present this topic at the European Respiratory Society 2020 virtual conference, where members of the European Lung Foundation saw it and requested I also record a version for them. So here we go. Now, just in case you have to rely on not being able to see me, and I suspect you can't as I'm recording this presentation, I thought I'd better include a couple of photos of myself so we all know what I look like. Now, these photos of me are at work in my practice, and me being a bit playful and carefree, getting ready for a Halloween celebration, smack bang in the middle of house renovations. As you can see, I went as a witch, my natural state of being. On a more serious note, getting back to why I'm actually talking to you today, the aims of my presentation were to help clinicians of all sorts increase their empathy skills. So we really wanted to increase skills and knowledge in interpersonal communication, increase empathy and psychologically focused skills based on patient-centred care, and also to reinforce anyone's understanding that psychological health and physical health are inextricably intertwined. So if we're going to talk about empathy, I guess we really need to understand what empathy is. So what is empathy? Well, firstly, of course, it's a noun. But seriously though, empathy and sympathy are two words that I think are often confused and used interchangeably. Now, it's easy to confuse the two, and I guess there are some subtle differences. For me, empathy is when we make an effort to truly understand how another person feels, whereas sympathy is something we tend to give to someone or a person without necessarily attempting to step into that feeling. So in a clinical perspective, I actually think this definition is probably the most helpful when we undertake to understand what exactly empathy is and how do we, as clinicians, be the best version of our empathic self. So of course, this definition is the part about guiding our actions that I actually think is most useful. So if we are going to use empathy to guide our actions when caring for and treating patients, do we then follow the golden rule of do unto others as you would have them do unto you? And of course, the answer is a big fat no. And just to labour the point, no. And the reason for that is what you need and what they need to stand in their shoes might be very, very different. So the act of practicing empathy is all about actually developing your curiosity and discovering what it is that the person actually needs, not what you think they need. So that comes to the thing, and I'm sorry that this isn't probably quite as easy to read as I would like it to be, but it means that a one-size-fits-all approach is actually not what we all need. As we deliver tailored pharmacological approaches to lung disease, we also need to deliver tailored psychologically focused empathic approaches to our patients and our caregivers. Now, it's all very well having on hand great resources and developing groups that are more of a one-size-fits-all, that have some basic generic information to it. But the problem is that if we are going to deliver true CBT, the T actually stands for therapy. And part of therapy is developing a therapeutic alliance, and that capacity to tailor approach to make it applicable to each individual is one of the greatest challenges and reasons we do therapy. Now, the impact of that and the fact that empathy plays a big role in creating that really strong therapeutic alliance is so important. So how do we create empathy? I hear you all virtually ask. Well, the next slide is a good beginning at doing that. So I've entitled it Increasing Empathy because most of us actually would like to think that we are kind and empathic people, and most of us are. But in order to increase our empathy and to make it really, really valuable to our clients and their caregivers, we begin by developing our curiosity. We develop our curiosity about people, things, and places. And the more you practice being curious about things outside of yourself, the more empathic you're likely to be. We all know and have probably worked with someone who's quite narcissistic and self-focused or self-centered. And that person that we've probably worked with or known has also probably been the person with the worst bedside manner. Developing curiosity helps you to imagine walking in their shoes. What does your patient need? What does their diagnosis mean to them? Do they understand it? Is it life or role changing? Do they have family or social supports? Can they afford the medicine? When you say exercise or eat healthily, do they actually have the knowledge and or the skills to undertake what it is you advise? Curiosity will help you find those things out. Point 3, of course, is asking you to challenge your own prejudices and preconceived ideas. And I think this is a challenging one for most people because we all have prejudices and preconceived ideas. They help us to make sense of our world. But sometimes these preconceived ideas are not at all helpful, especially when it comes to patient populations. The 4th point asks you to practice active listening. Now, this is a skill and anyone can develop it. It helps people to feel heard and it's easy to do. In its basic form, it involves to listening to the person and then repeating or reframing it back to them in a slightly different way. Point 4 also talks about making yourself vulnerable. It's about appearing human and not too godlike. It helps our patients and caregivers to know that you too are not perfect. But be careful about being vulnerable. Your stories shouldn't be too long and they should be clinically relevant, so don't labour the point. Inspiring others is absolutely fabulous. Anyone can inspire others. You don't have to have a public profile to do it. Speak up, be an advocate, tell others what makes you passionate. Inspiration can come from the most surprising quarters. And of course, the last one is we ask people to empathise with those who are opposite to us. And again, I think this is one of the hardest things to do. Empathising with people we don't quite understand or who share a different perspective to us allows us to develop our curiosity and possibly discover why they hold the beliefs that they do. And then we can work with that. So if you type in empathy and clinician, why that happens is what we think impacts what we feel. Thoughts and emotions have a profound effect on one another. Thoughts trigger emotions, and which can then trigger more thoughts about our emotional response. And in addition, we tend to use those internal schemas, those things about our preconceived ideas and stuff, to help us appraise our lives, and that has an effect. Now, this is really important because we're all influenced by our internal schemas. That can be culture, socioeconomic status, age, gender, and many other things. And these things help us interpret what others are doing, saying, and not saying. And so this is important because here's where it all starts to tie together. Our patients rely on us to help them through their lung disease journey. For some, this might be a brief journey, but for many patients, it's a lengthy time. And our patients are really good at masking their distress from the clinicians, which is why we need to be curious and delve. And so if someone says, I'm doing okay, don't just take them at their word. Maybe ask another question or two and find out if they truly are. So here are some things about practicing and being empathic that I've learnt from my patients. We've all had patients that have had fabulous and often unexpected outcomes. Those who have responded to treatment much better than expected or have beaten the odds. And when this happens, it isn't unusual for us to praise them and let them know just how amazing they are. Now, on one hand, this can be motivating and inspiring, but for many of our patients I see who have experienced this, they feel like they can't complain or actually let the treating team know that they are struggling. If we do praise our patients, we need to also let them know that it's okay not to be okay and that they can tell us when they aren't. And so don't forget to add in that it's okay to have a bad day, even if you've had a fabulous response. The next slide talks about what happens when they aren't doing okay. So my patients, I'm lucky because I get to spend an hour with them or more sometimes. And what they've told me is that when they are distressed, they've learnt to mask it well. So their distress is not always obvious. It might not also be immediate. And distress is one of those funny, ironic, but not funny, ha-ha things. Distress to bad news is to be expected, it's natural and a normal reaction. Most of our patients will experience it to some degree. It is also an ongoing and significant problem for many patients, their caregivers and loved ones. And it's really important to check in with the caregivers too, because they shoulder quite a significant burden sometimes. It's mostly under-supported. Nearly every study I've read says that our patients and caregivers feel like their journey has been under-supported. Now, patient distress can be connected to exacerbations, but not always. And in most cases, the impact of distress is underestimated in terms of treatment adherence, mortality, and morbidity. So I hope by now I've helped you to understand, and I've developed a good argument for why we need to develop our empathic skills and practice them at every opportunity, because it's so important. But for every light, there is a shadow. To every positive, there's a negative. And there is a negative side to empathy. And I'm glad you asked what it might be. The negative side to empathy, we call it vicarious trauma or burnout. Many studies have found that vicarious trauma and empathy are really closely related. And in fact, the Diagnostic and Statistical Manual of Mental Disorders acknowledges that vicarious trauma is often experienced by frontline workers who witness patients and victims' distress. It can manifest at worst into post-traumatic stress disorder. So this is why it's really important for us clinicians to have a peer network where you can download and share experiences, ask advice, and share the load. People who take advantage of their peer networks to discuss the more tricky or distressing cases are less likely to suffer burnout and vicarious trauma. And it's really, really important to practice self-care. It's also important for our carers to practice self-care because they too are at risk of getting vicarious trauma from the support they give to those people who have a lung disease. And so to finish up, I just wanted to briefly touch on self-care. Now, 2020 certainly was a challenging year for most of us, and in fact, the world became unpredictable and uncertain, and I suspect 2021 won't be much different. For many of us, the impact of this is that we work longer hours with more pressure, and we're human just like our patients. We worry and we stress about our families and our loved ones too. We must try to practice some self-care so we can continue to do the needful, not just for our patients, but for our colleagues, our families and friends as well. For me, some self-care often involves being curious, a little carefree, and almost adopting a childlike curiosity about the world. And if it's raining, this may occasionally include jumping in a puddle or two. You should try it one day. It's liberating and so much fun. Here are my references. Thank you for listening. Happy to answer any questions via email.
That's great. Thank you very much, Deborah. Rita, I understand you've got some questions for Deborah.
Yeah, first of all, thank you very much, Deborah, for taking your time and answering my questions. Do you think empathy is sometimes not practiced in the doctor office because of fear of suffering vicarious trauma you spoke about?
The short answer to that, I guess, is no. I don't think that is the sole reason why doctors tend to come across as unempathic or not as empathic as the patient and probably the caregiver who might accompany their patient into that room. I think for our doctors, many of the challenges that they have is that, they have a limited period of time, 15, 20 minutes, maybe half an hour if they've booked a long appointment, in which to deliver a lot of information to the patient. And that can be the results of lung function tests, blood tests, x-rays, CT scans, pharmacological review, and all of that information in many ways is quite black and white. It's quite right. Well, your lung function test was this, and we've seen that you've remained stable or that your lung function has declined by this and that. When they talk about pharmacological things, it's very that you talk about symptoms, and so we talk about maybe swapping a medicine, or we might tweak it a bit. We might raise the dose or we might lower the dose. And again, with x-ray results, they're giving the results of tests. And so I think in many ways they're time limited, and that impacts their capacity to adequately express what we would like as empathy. And I think, you've shown in your questions to the other participants, Karen and Ron, that for patients sometimes and caregivers, it's quite a frustrating journey going through a disease process. Lung cancer, and in fact cancer in general, is very well supported across the Western world, and we have a whole team, a multidisciplinary team around the patient and the caregivers through lung cancer. But for patients with sarcoidosis or IPF or interstitial lung disease, and even COPD and other lung diseases, we support far less well, and that's here in Australia. And I believe it's a similar situation in the UK, through Europe, and indeed in America.
Thank you. I have another question. I have a couple more questions for you. In the med schools, are doctors trained to be empathic or to protect themselves from the burnout syndrome, or none of the above?
So here in Australia, I'm part of the medical school as well. And our undergrad doctors, when they first come in as fresh out of high school and predominantly and into the medical degree, that these days here in Australia, and I assume it's the same in the UK and elsewhere, there is a greater focus on both vicarious trauma or burnout, so self-care, but there's also a big focus on empathy because, like Karen said earlier, mental health and physical health don't happen in separate vacuums. They are inextricably entwined, and that knowledge is well accepted now. And so we are getting better at understanding that not only do we need to address our patients' physical needs, but we also need to address their emotional needs. And not only do we need to address the patient's physical and emotional needs, but we also need to take into consideration what support systems they have around them, and that is the needs of the caregiver and their families. And so I'm doing a research study at the moment, which I've turned into a PhD, which is looking at just that. And we've designed a psychologically focused support group, which encompasses all of those things that you talked to Ron and to Karen about. So it's informing them about their disease, it's providing support for caregiver and patient. And not only that, it's incorporating ACT, which is a form of CBT, so acceptance and commitment therapy, and it's giving people skills to manage some of those more distressing emotions which stop them or prohibit them from maybe doing the best thing for their own physical health. And doctors are becoming more and more aware of that, and they are teaching that in medical school. So I think a greater focus has become, this is a very long-winded answer to a very short question, but a greater focus has become more evident in our junior doctors coming up through the ranks, that they are taught to try and be empathic and to consider the emotional needs of their patients, and also to remember that, you know, it rubs off on them and to protect themselves.
Thank you. Just linking your last answer to my last question. In your presentation, you said that better patient outcomes are seen in empathic doctor offices. Do you think that empathy is something that could be taught? I mean, someone could be trained to be empathic.
So, yes, we can teach empathy, but I think for many people, being naturally empathic is a very big skill as well. And so it's like any skill. We need to teach people how to, I suppose, take advantage of their natural inclination to want to help people. And, you know, most doctors become doctors because they have that thought. They have a view of, I want to be helpful to my patients. I want to make people feel better or hopefully cure people. And indeed, nursing staff and allied health staff are exactly the same. So getting those courses and having that as part of a PD, again, is a big passion of mine. Hence the symposium for the ERS where I sort of gave a mini masterclass, I suppose, on some of the skills of highly empathic people, and talked about, you know, not only the patient needs but the caregiver's needs, and thinking about that within that consult room. And I would like to see, in our perfect world, that we gave our doctors more time with our patients, and that we maybe change some of the practices. So when we were delivering bad news, we made sure we got the patient back next week, or we booked them in to see someone like myself or someone like Karen, who can offer that wrap-up support because, you know, when you get a disease that's of a life-limiting lung disease or a diagnosis, then it's shocking, and it takes you a little while to get your head around it.
Thank you very much. I have a last question. I just launched it to whom I'd like to answer. So is it possible that a multidisciplinary approach and addressing the patient as a person, not a patient, not symptoms, not organs, and delivering accurate information about the condition, but also expectations, follow-up, chances of disability, psychological help, support groups, associations, where to find a social worker to help with paperwork, etc., will save a lot of anxiety, fear, and emotional distress to the chronic patient. Is this science fiction? Is it possible? It's been made? Is it somewhere that it's been doing right now?
I'd like to say that I don't think it is science fiction. I think we should be providing that, and often we don't provide that. I think it is getting better. There are now multidisciplinary teams for interstitial lung disease, for example, for asthma, and obviously for lung cancer. That is the approach that we're all aiming for, because we know that provides better care. And I think, from my point of view, people at the front line need to learn basic psychological skills, and I do think we need to do that better, so that we can help address psychological well-being for everyone as in our standard care. But obviously there will be some patients who need more psychological support and expertise that we at the front line can give, and hopefully we should have the facility to provide that psychological support and social support for our patients. That's ultimately what we want to do, and I hope that my CPT skills helps me look at an individual rather than a person with lung disease. That's important, but it's the whole thing about it. And so for me, providing holistic care looks at all those things, and we're all supposed to be doing it anyway, just some are doing it better than others, I think. And psychologists are as rare as hen's teeth. We need psychologists to supervise the rest of us to make sure we are providing better psychological care. And I think we've got a long way to go. I don't know what Deborah thinks of that.
No, look, Karen, I totally agree. I think that you're exactly right. Everyone should have some basic, what we would call psychological first aid. And so, it makes my job easier if the doctor and the nurses have been able to provide, some basic understanding of the emotional distress that everybody is going to feel at some point. And I think that's the really important part, is that some people have an immediate distress response, and other people, it just takes a little while, and then when it hits them, they go down like a bomb. It's just horrible. The other thing in that perfect world scenario is, at the end of the day, it comes down to money. The squeaky wheel gets the oil, my grandmother used to say. And what that means is that we need patient organisations like the European Lung Foundation, like the Lung Foundation of Australia, like all of our other patient advocacy groups, to be loud. And how we will convince governments to provide someone like me as part of every multidisciplinary unit, the same as we now have physiotherapists and speech pathologists and OTs as part of that unit, is we need to show how they can save money ultimately by having someone like me in that unit. And we do that by hiring the bean counters who can show it in a financial way. And we know it because small studies have been done, but there are some fabulous people over there in the UK who do that population financial health budgeting. And that's the way they got the NHS how it is today, by showing financially it was worth doing. And we need to do that again. And that's how we get that perfect world solution to this problem. We know it's a problem, and there's people like Karen and myself and all the other fabulous nurses that I know, Anne-Marie Russell and Kathleen Lindell and all those people who do amazing things with their patients, but they are only one person, as am I. And that's why every 5 minutes that if you give me a soapbox, I'll stand up on it and I'll shout from the rooftops, give us more money and help us help the patients. And that's exactly what we have to keep doing. We just have to keep doing it.
I think in a way, as being a patient, I can remember back to the dark days of 2014, my consultant saying you've got 3 to 5 years to live, and et cetera, et cetera. And I can remember I was in some very dark places. I lost my job as a result. So I was in a downward spiral, and my ILD nurse said, you'll have a roller coaster of a ride. And I think in an ideal world that would be great, but I suppose that in some way that's the way that the hospice has taken on board for me. I only went to hospice because one of my friends said, do you know the hospice is there for you? So I suppose in a way the hospice has taken over that role and look at me as a person and saying, Ron needs this, Ron needs that, and we need to support Ron in this particular way.
Yes.
Yeah.
And Ron, you're very correct. Over there you have the hospice. I think we need to take the scariness out of the word palliative. Many people, when they hear palliative, feel that it means the last 6 weeks or so of life. And we all know that palliative actually should start almost from the moment you are diagnosed, because it's how we help you to lead the best quality of life we can possibly get our patients to lead. And that palliative care aspect to any life-limiting lung disease is so important. And we need to somehow get across to patients, and indeed some doctors who don't understand truly what palliative means.
In our ILD clinic, we have palliative care in the clinic, and they are there from the beginning, and
Yes.
that's the way it is. So we try to get our patients plugged into the hospice, whatever they need, from day one. But going back to your point about, Deborah, about the cost effectiveness, a lot of long-term conditions, particularly lung conditions, that we can't cure them. So the aim of treatment, and as often stated in guidelines, is to improve quality of life and improving psychological well-being. Supporting patients in a holistic way improves quality of life, and there's lots of evidence and studies for that. Unfortunately, people who pay for things are not interested in this soft, touchy-feely kind of subject. You know, you can't really put your finger on how you're helping the patients, but the patients tell you are. But it actually does save money. So in my study, which is the biggest study in the world in COPD of all severities, we did help reduce symptoms of anxiety, which was very beneficial to the patients, and we did improve quality of life. Unfortunately, nobody's interested in that. I couldn't get the study published until we did a health economic analysis like they do for NICE, and it showed it massively reduced attendance to A&E and hospital admissions. And that's now what they're interested in. And it's a shame that the holistic care and the reducing anxiety, improving quality of life wasn't as important as reducing hospital admissions. I agree, it is important not to go to hospital for the patient and for the health service, but it shouldn't be the only thing that we think about. And it was as cheap as chips. So that my intervention that I taught people, a brief intervention on psychological first aid, absolutely helped people in all kinds of ways. It was a win-win situation, and it was very cheap and effective. So I don't see why we can't push for that. And I've been standing for years going around and saying the importance of, and as if I've got two heads. Half the time I go to medical conferences, some people are just not interested in the slightest, and it's such a shame. So I'm getting off my soapbox now. That's me done.
There you go. We've both been on our soapbox. But you are right, and you had a fabulous study, and you couldn't get it published until you brought in the dollars and cents to it. And, and I guess it's what, if I put my psychological hat on just for a second, it's thinking, okay, how do I get across to the people who have the money? And most of the time our funding comes from governments, and that's what they understand, isn't it? They understand budgets, and they understand that. And so we almost have to split it in two, because for us, the clinicians, it's most important that we help our patients have the best quality of life possible. But in order to do that, we have to then convince the politicians to give us the funds. And so we need to think smarter, not harder, and think, okay, if I need to get into a politician's head, how am I going to do that? I'm going to show him how he can save, him or her, they can save money. But if I'm going to get into a patient and caregiver's head to help them, I'm actually going to do that soft, touchy-feely stuff.
One question that comes to my mind in these COVID times, it's that, do you find it easier or harder to get this multidisciplinary approach and to get experts intertwined in these digital health times? Do you find it easier or harder to get teams of experts together, or do you think it's harder?
It's different, I would say. And we spend a lot of time. You can still have multidisciplinary teams and meetings, and you can even have them with the patient. In the UK, they're developing digital platforms where you can have the patient and the carer and the physio and the nurse and the consultant together, I think it's very early days. I don't know how easy it is for patients. I'm all for just, it's got to be simple for the patient, just to click a button, join, and not to have to log on here and do this and put a password. It's got to be simple. And obviously there are some people who don't have digital access. And we've got to remember that we have to make sure that if you prefer a video consultation, great, you can have that. If you prefer a face-to-face one, then you can have that. So that's just my view. It's different and something we're going to have to get used to.
I could just add from that, pulmonary rehab, the hospital I'm being treated at obviously do online pulmonary rehab, and that actually saves us travelling 30, 40 miles or going to a hospital and coming home again. So the pulmonary rehab has become a lot easier because we're doing it on a weekly basis now. And it's just not a 6-week course now, it's been extended.
And, you know, with psychology, of course, being able to talk to patients video like we are doing exactly here, it means I can deliver therapy in the worst of COVID situations. If someone's got internet access, I can still offer therapy. In terms of meetings, well, I'm here from Australia and you're here from Spain. And so, you know, it would have been very expensive to fly both of us to the UK for a 1 hour meeting. So that's been a benefit. And the last one that for me personally is part of the research I'm doing for IPF patients and their caregivers was to do this support group. And I was looking at trying to involve 5 different hospitals, and getting the funding for me to travel between South Australia and Victoria was cost prohibitive, and it looked like the study was going to cease because of finances. And now that COVID has hit and it's shown us that we can do so much by the internet, I now have the excuse to go back to my ethics committee and say, I want to deliver this group online. And that means that my country patients, interstate patients, and indeed people like Ron, if they wanted to take part in this study and join the group, could. So there's, I think, some real benefits for, you know, some of the things that we've been forced to do, and that we might be able to continue on. Of course, there's always going to be negatives, but, you know, I'm a glasses half full girl, so I try and look at the positives.
Yeah, we had interesting chat with Dr. Usmani and with Dominic Hammerling, and we were speaking about combined attention. Digital attention and face-to-face attention would be maybe reality in a perfect world or in a medium short time. And yes, because there are people who have no access to the internet or just don't want to be visited by the internet, just prefer face-to-face attention. Yeah. Thank you very much to all of you. It's been a great pleasure.
Thank you, Rita. Thank you for coming up with some really thoughtful, thought-provoking questions.
Yeah, very.
And to Deborah, Ron and Karen for some really interesting answers as well. So it's given us a lot to think about.